So this session is called Community and Rehabilitation Services, the key to easing gridlock. And while I think we're going to look at some of these services through that lens, and it's probably also worth bearing in mind more generally that as a country, I think we're some way off the pace in terms of the community and particularly the rehabilitation services that we provide more generally. So the issue is not just about unblocking the hospital. That's quite a useful way into the debate, but we should just keep in mind as we go through that there's more to those services than just ways of dealing with issues in the hospital. We're going to have a sort of two-phase discussion, picking up some of the themes from what I was talking about before lunch, where we're going to think about some of the problems and then what might be causing them, and then go on to think about what some of the solutions are. So we'll try and do it slightly in two parts. First of all, you're going to hear from Sarah Scobie, who's Deputy Director of Research at the Nuffield Trust, who's going to give us some data and set some of the context. And then we're going to have contributions from Juliet Bouverie, who's Chief Executive of the Stroke Association and also Chair of the Richmond group of Charities. Sarah McLinton is President of ADASS and Director of Health and Adult Services at the Royal Borough of Greenwich in London. And we're stepping in for Charlotte Williams, who can't be with us unfortunately, is Tara Donnelly. She's here in her capacity as the founder of Digital Care, which is supporting tech innovators and healthcare organisations change home care, revolutionise digital home care. She's speaking in that capacity, but of course you'll be aware that she has had, in fact still do have an NHS hat as well. So her hat is off today. You'll have to. It's a metaphorical hat. It's not there. So that's the running order, and there'll be opportunity, as with the previous session, to contribute to that. So I'm going to hand over to Sarah, who's going to set some context for us, and then we'll hear from the others. Thank you, Sarah.
So thank you very much, Nigel, and it's great to be here today. So I'm going to start off with just talking through what we know and don't know perhaps as well about patient discharge. So this has had a lot of profile recently, and I think increasingly the back door of the NHS of hospitals is being seen increasingly as a key to understanding what's going on with the wider system. So just to start off with, this chart is looking at the number of people in hospital who've been there for more than 3 weeks, for 3 weeks or more, and this has grown fourfold since April 2020. So we can see that there's a real issue here, and with this many people in hospital who've been there for 3 weeks or more, you know, it's not surprising the access to hospitals, A&E, ambulances, etc., are in the state that they are. Now, obviously, in April 2020, there were good reasons why there were fewer people in hospital because of everything that was done at the start of the pandemic. But it's important to note that in the year up to December 2022, the number of people in hospital for 3 weeks or more has increased by 35%. So this is an ongoing problem. And there's good reason to believe that delays in discharging patients are part of the reason why there are people in hospital for such a long time. It's almost certainly not the only reason, but I think it's definitely part of the picture. So this analysis here is looking at the number of patients delayed, split between those who've been in hospital for between 1 and 3 weeks and those who've been in hospital for 3 weeks or more. And it's that latter group, people who've been in hospital for 3 weeks or more, where there's been this real increase in the number of patients delayed. Now, just to say here that the definition that I'm using is the NHS England definition for whether people have a medical criteria to reside, and that definition is quite narrow and more stringent than pre-COVID definitions. There are, there's a lot of debate about that definition, but nonetheless, we can still see a growing problem there of people delayed who've been in hospital for some time. And I think that this raises a question that was touched on earlier actually about sort of cause and effect. So is being in hospital in itself likely to lead people to need to be in hospital for longer? Or perhaps there are different reasons why people are delayed, and are they waiting for different things? So we can go on now to have a look at that. What do we know about the reasons for people being delayed? So the top bar of this chart looks at everybody who's been in hospital for 7 days or more, and the bottom bar is just those people who've been in hospital for 3 weeks or more, so a subset of the top group. And just under a fifth of patients, that blue group, are delayed for reasons that are to do with their assessment in the hospital, or what's going on there. So they're waiting for a discharge summary, for medication, they're waiting for an additional therapy assessment. There isn't a plan for them. Then there's about 25% who are waiting for care at home. So that could be community health services, assessment, physiotherapy, rehab, district nursing. It could be social care services, so it could be domiciliary care at home, or of course it could be some combination of the two. Then there's around 22% who are waiting for a short-term bed, so a rehabilitation bed to help them recover enough to then be able to go home. And then around 18% are waiting for a permanent care home. It could be a residential or a nursing home bed, and then there's a bunch of other smaller reasons. And we looked at this last year and found a pretty similar profile of reasons. So these reasons haven't really changed very much. And in terms of the difference between the two groups, so people who've been in hospital for 21 days or more, they actually have a fairly similar profile. More of them are waiting for a permanent bed, but there's still quite a chunk for whom their assessment in hospital isn't yet complete, so around 14% of patients. And so what does this tell us about capacity? So I think it's just worth bearing in mind that around 85% of people who get discharged go home without any help at all, or any formal care. It's worth bearing that in mind in terms of the overall numbers. So here I'm looking at people who've been in hospital for 3 weeks or more, and in an average week, how many of them were delayed and how many of them were discharged to each of these three main settings. And so in each week, there's about 1,500 odd people waiting for each of the care settings. For people actually discharged, people going into back to their own homes with care, more of them do get discharged, but it's still under half, and the proportion who do get to go home falls to around 35% for people needing a short-term bed, and around 28% for people needing a permanent bed. So, in summary, there isn't much evidence here that things are going in the right direction. Helen Watley talked about turning a corner. I can't see a lot of evidence for that from the data that we've got here. The proportion of long-stay patients in hospital has increased. It appears to be continuing to do so. A growing proportion of delays are faced by people who have already been in hospital for a long time. The reasons for delay are split between things happening in the hospital, needing care in their own home, short-term rehab beds, permanent beds, and there are capacity challenges across all of these pathways. And just one final point to note is that this data's based on acute SITREPS data collected by NHS England. It isn't routinely published, and so I think there is a lot more that could be done if the data was more readily accessible and was easier to use and navigate. And I just want to finally thank Laura Schlepper and Emma Dodsworth, who've done a lot of the analysis. So thank you very much.
Thanks, Sarah. Perhaps before I turn to another panelist, I might just ask a couple of clarification questions that might be helpful. So this is a stock problem and a flow problem. So there's a stock of patients, but it's increasing over time. Do we have any feel for what that stock of patients looked like prior to the pandemic? In other words, is this a problem that is getting worse over time, or are we just returning to pre-pandemic levels, do you think?
Well, one of the challenges is we can't directly compare because the criteria are different. So pre-pandemic, delayed transfers of care as they then were increased until about 2016-17, and then there was a big effort to reduce the number of long-stay patients. And it did go down prior to the pandemic, but it now just seems to be going up.
And just elaborate a little bit more on, I think you were implying that the criteria to reside might mean that this is a tip of a bigger problem. What's your view on that?
Well, I think that one of the things to bear in mind is that we don't know anything about people who have been in hospital for less than a week. So if you were delayed one day from 5 days to 6 days, we wouldn't know about that based on this data. But in terms of the criteria, they're narrow in terms of you might be medically fit, but have other care needs that might still mean that being in hospital is the right place for you. Whereas previously the assessment was more of a multidisciplinary assessment rather than a medical one.
Thank you. So let's dig in to some of this and get some different views on the nature of the problem, and we start to then think about what to do. But I think I'm going to come to Juliet first, for your perspective.
Thanks, Nigel. Nice to see everybody. So I wanted to remind us who we're here to serve, which is obviously patients and their families. And I was just reflecting before this talk, I've actually worked in health and care for 30 years, frighteningly, and we have had so many reports published on what good care looks like from a patient perspective. And we bandy around these phrases, I'm still me, no decision about me without me, focus on what matters to me, not what is the matter with me. And yet, we know time and time again the system is failing patients and their families. We know that care is organised around disease silos. It's not organised around people's lives. Care's fragmented. It's not wrapped around the individual and personalised. Mental health and emotional well-being are consistently overlooked. And we were talking this morning, weren't we, about poor health outcomes being affected by social determinants. So we know what some of the problems are. And I suppose I wanted to just kickstart my bit of this panel debate with sort of five thoughts for the audience. The first is I think we need to be more intentional in our focus on multiple long-term conditions. And the slide that's now up reminds us of the burden of people with multiple long-term conditions on the health service. 2/3 of inpatient bed days, 70% of the total spend is on people with multiple long-term conditions. Multiple long-term conditions are an expression of health inequity. We know that multimorbidity occurs 10 to 15 years earlier in more deprived areas than less deprived areas. So my challenge to all of us is how can we be more intentional about focusing on multiple long-term conditions? How can we implement some of the good practice that's out there? And how can we potentially look to neighbourhood teams to really be those people who wrap services around the needs of individuals and their families. My second premise, which Nigel's already touched on, was let's get back to basics. How long have we been talking about personalised care? I reminded myself, I went onto the NHS England website this morning about the 6 principles of personalised care. We know what good looks like. We know that we need to value experts by lived experience. We need to co-design services. We need community solutions like social prescribing. How can we get these basics right? My third challenge is how can we embrace the voluntary and community sector as a strategic and equal partner. It was interesting in this morning's conversation, lots of really welcome talk about the need for integration between health and social care, but the voluntary sector is a major provider of the solutions that really matter to people living with multiple long-term conditions, solutions that really do improve people's quality of life. And we deliver services. We're also big custodians of rich data and insights about lived experience. And we're often quite innovative in our models of service delivery. So how can we be involved more as an equal partner? My fourth challenge is let's invest in rehabilitation and recovery services. I mean, how long have we been saying that? But we see them as a cost, not actually as a solution to prevention, not actually as a solution to helping people get back to work and contributing to the UK economy. The Community Rehab Alliance has produced multiple really good quality reports. Let's get on and implement what they say. And then finally, let's collect the right data. So much of the data that we collect in health and care is about interventions, it's about money. It's not about patient experience. It's not about patient-reported outcomes. And I have to say, we've just had an experience at the Stroke Association of piloting a stroke PREMS, a patient-reported experience measure survey. I could go on. It has been an information governance nightmare. And yet, patient experience data can be a real catalyst for service improvement.
If some of this problem is a stock problem, rather, is a flow problem, is capacity, how much extra capacity, and where would you put that capacity if you're going to invest? Because if it's a bit like if you've got a stable stock of people and it's always that level, if it stops growing, it has been growing. If it's growing, that's just we're short of capacity. If it's stable, it means we've just not got our decision processes quick enough.
Yeah.
Perhaps. I just wondered, do you want to just unpick that?
Yeah, I mean, I think there is
a bit of both, perhaps? Or,
yeah, maybe. Yeah. I mean, I think that there is definitely a capacity challenge in community services. I mean, they've been underfunded for decades, and now with this aging population, more people living with multiple long-term conditions, it's creaking at the seams. But I would also argue that the voluntary and community sector has capacity that's not being fully deployed. So often you see community teams are not as integrated with all the different actors in the system as they could be. So I'm not convinced that we're using the existing capacity to full productivity and effect. And my worry is that if the voluntary services continue not to be funded on a sustainable basis, we're going to wake up in 5 years' time, realise their value, and some of those services just won't be there.
Thank you. We've made the mistake of having two Sarahs on our panel, but
confusing.
Which can be slightly confusing. But come to you, Sarah, if I may. Yeah.
Thank you very much. I suppose I was going to pick up on that theme from earlier. I think we're very good at describing the problems, but I'm not sure that we always do fully understand what the problem is. And we've definitely seen some quick solutions over this winter that clearly haven't worked. I was going to do a little bit of myth busting, I guess, and talk a bit about language. Because I think if we listen to health leaders and others over this winter, you could be forgiven for thinking that there were 14,000 people sitting in hospitals twiddling their thumbs waiting for social care, and local authorities just needed to get their finger out. And I think that the data that Sarah's presented is really helpful. It's interesting that's not published, but it does show that in fact 85% of people don't need support to leave hospital. There are undoubtedly challenges in social care, and we've already heard some of that this morning. But I think this oversimplified narrative that's been created is really unhelpful. Local authorities have seen huge increases in terms of the levels of activity, so councils have really kind of stepped up. But in fact, people who are referred in hospital to social care, less than 3% of them actually need to go into a care home, and yet the solution often seems to look to care homes. So this binary debate about it's about hospital processes or it's about social care, I think it is not helpful. And then I think there is a problem about the language, and we talk about flow, and there's this focus on discharge. We've talked this morning about the need for prevention and stopping people going into hospital. That's kind of obvious. But I think what we're talking about when we talk about discharge is actually transfer of care. It's a particular point in someone's life when their care needs to move from hospital, ideally back to their home. And as your data shows, actually getting people back home is easier, and that's where we ought to be focused. But I think it's important, the language, because remembering that it's a person at the centre of this. And actually, well, I was on a discharge summit in my ICB this morning, and my chair's here, so I have to say we resolved all of these problems this morning, Richard. But I was really struck when an acute colleague on that call said, we're losing the patients in the process. And it was the point that I think Jane made this morning, really, about these are people with thoughts, feelings, families, homes that are sometimes hoarders, and all kinds of sort of issues that we need to understand if we're going to have that person-centred care that Juliet has talked about. So I think it is really important to understand that it's about the services that are available to support people in their own homes across voluntary and community sector, the NHS, and across with social care. And those services need to be much more joined up if we're going to be able to offer those much more reablement recovery-focused services, because we can't just keep creating more capacity. We have to also use the capacity that we've got in the best way, and that means we have to have much more focus on recovery and supporting people to be independent in their own homes.
On that issue about service, if I asked one of your senior staff to draw a map of all of the community and social care services that are available, how easy would it be how long would it take them, and how easy would it be to do? Could they do it?
If you're talking about my staff, I think we could show you where all the social care services are in terms of
and the community services.
Well, I think the point is that actually the way that we have to think about the way that people live their lives, and it's not all about services. Yeah. It's actually about what are the assets in people's local communities, and how can we support those? How can we build those resilient communities and do that work that's about real prevention. Prevention isn't just the vital five. It is about social care that keeps people well and healthy in their own homes. No, it's about our public health services.
Yeah, I totally get that. I was picking up something slightly different that you also said, which just strikes me when I have done bits of work in areas, and you try and map all of the different types of community and social care and voluntary sector provision that's available. What you find is sort of quite big differences in areas of provision, levels of provision, even within the same area, for reasons that are not at all obvious from the characteristics of the population. Archaeological layering of different initiatives and things that people have put in place, that referral criteria that don't line up with each other, and sometimes, I mean, you find this in hospital too, are designed to tell you why you can't take the patient, rather than actually sort of fitting together into coherence, and then actually being so complex that it's not at all clear who's got the. It's all very, I mean, it's quite interesting to hear Helen what they talk about having a control room, but I just wondered would it look like Clapham Junction? Or would it be rather simpler? Because I think the complexity of some of this stuff I've found a bit. Maybe people have got comments on that, and when we come to the audience, it'd be interesting to hear that. But
come back on. Yes, I mean, I think there's obviously huge complexity in terms of different levels of services. I think that's where social prescribers can be very useful, and I think even our own staff in our hospitals or wherever often have got this completely mad kind of world where they can't understand all the different pathways and the different kinds of criteria that there are for those. I think there is also the point, though, that there is difference in terms of different local issues and local solutions. So if I look at my local patch, for example, those people living in a deprived, particularly deprived part of the borough are twice as likely to turn up at A&E. So why wouldn't we have different services in those in those communities? I think that's
I mean,
that's
the
really
question.
important.
The question then, of course, is do you, and actually are they aligned? Because I suspect the inverse care law probably may also work in community services as well as in.
But I think that's why you have to try harder to
Yeah.
make sure that you have got a different offer.
Try harder is definitely a good maxim. We'll take that. Great, thank you. Tara.
Thank you, Nigel. So I'm Tara Donnelly, and I've worked in the NHS for 3 decades, mostly in hospitals, running services as an ops director and a chief exec, and then latterly, for the past 4 years, running a national programme working with partners to scale digital home care. And I'm thinking about Helen Whately's grandmother and the fact she's not alone. I mean, she was rather alone, wasn't she? But there's a lot of people like Helen Whately's grandmother who spend much of their last 1,000 days in hospital. And so I'm going to come at this from a slightly different perspective, trying to think, if we look back from that person who's experiencing the delayed discharge, and the figures, you know, can't help but make you really sad, because 3 days in hospital is pretty awful, because you can't sleep, you don't really eat properly, you don't mobilise, you don't see loved ones, pets, your social network's gone. 3 weeks plus must just be awful. People might remember that in November, Adrian Boyle, as he joined as president of the College of Emergency Medicine, said to the Daily Mail that NHS hospitals are like lobster traps, easy to get into but hard to get out of. He went on to say that he was desperate to keep his elderly patients from going to hospital this winter because he fears they'll never come back out. We know that home has enormous advantages, and the points about sleeping, eating, being with people you love speed up recovery and improve morale tremendously. I thought the last session before lunch became more optimistic as it went on and ended up talking about solutions and doing fewer things well. And I'd love us to do more on this, to do more to keep people well at home. The evidence about staying too long in hospital really is very compelling. Muscle wasting apparently starts within 24 hours of admission. It can be hard and, in some people, particularly the elderly, impossible to recover from. And it's especially problematic for people with any cognitive difficulties at all, who can become much more disorientated and distressed away from familiar surroundings and lose cognitive abilities and independence permanently. There was a really interesting meta-analysis on hospital-acquired deconditioning. The title is Not Only Physical but Also Cognitive, published last year by a group from Trinity College Dublin, talking about it being a strong risk factor for mortality, rehospitalisation and institutionalisation. Issues being falls, constipation, incontinence, depression, swallowing problems, pneumonia, demotivation and general decline, none of which are things people hope for. Many frail older people spend up to 83% of their inpatient time in bed. There's a movement about stop PJ paralysis, but how about we stop people going into hospital if they don't need it, or bring hospital level care to them at home? And of course, when I talk about home, I very much mean those 400,000 people who call, for whom home is a care home. The Nuffield Trust is obviously my favourite think tank. That is why I'm on its board. But other think tanks are available and often do really interesting work. And the Health Foundation did a great report called Emergency Admissions from Care Homes, which I completely commend to you. It's very stat heavy, but nonetheless heartbreaking for that read. One of the stats that jumped out to me most vividly is that 40% of people transported by blue light emergency ambulance to hospital from a residential care home return home the same day, right? But what a day they will have had, particularly at the moment. Lengthy waits likely in A&E, probably a bit of a wait beforehand in the back of an ambulance, to find that actually they did not need to be admitted to hospital. I think that is a huge failure, enormous failure. The Health Foundation think that most of that 40% is completely preventable with better care support in the home. One of the pieces of work that we've been doing is helping care homes use digital vital sign monitoring to check how well patients are. It escalates deterioration, but actually much more of the time, maybe 95% of the time, it's reassuring the staff in the home that there is not something seriously wrong with that resident and that they can keep a close eye rather than admit to hospital. In the best performing sites, and we've reached about 130,000 people living in care homes, there's been a 33% reduction in blue light conveyances. I would love to see more of that. We've touched on the potential around long-term conditions. COPD, a massive disease of health inequalities, can also, we're seeing some amazing sites such as Airedale that have reduced readmissions by 50% by using very simple, very cost-effective digital tools. I'd love to see more of that. So if we could do fewer, bigger things, I would like to wind the clock back a bit and see if that person actually ever did need to go to hospital, or did we just add hospital-acquired deconditioning that meant that their stay was inevitably going to be longer than 3 weeks.
Thanks, Tara. Well, I'm very aware we've got a lot of expertise on some of these issues in the room. So while this is it's labelled Q&A, I think it can be, I've got a comment or I've got an observation, either about the problem, understanding the problem we've got, or thinking about the solution. And I think it'd be good to acknowledge the fact that there's a lot of expertise here, but there's a lot of expertise in the room too. So it'd be good to hear from that. I've got Nick and Sam first, I think, and then Bola. Yeah, it is. Yeah, got the light in my right in my face there. So, shall we go to Nick? Yeah.
Okay. Thanks, Nigel. Nick Black, London School of Hygiene. Over 100 years ago, the city hospitals of this country, as in other countries, faced exactly the same problem. They couldn't empty their beds, which was then just bad for business and income. And what did they do? Well, largely they were the drivers of the creation of convalescent homes, often set up by trades unions and all sorts in mostly coastal areas. Now, we've lost all of those. I don't believe there was ever a policy decision to get rid of them, that we didn't need convalescents. But I'm just interested in the panel's views of, do you think a modern convalescent home, and it would also help the levelling up agenda, because most of those coastal communities are really suffering economically, so it's a win-win. Do you think that there's any role for convalescent homes for short stay to help alleviate the problem?
Interesting bit of history there. Thank you. Sam? And then if we can get the mic to Bola here in the middle.
Sam Everington, GP. Can you hear me?
I can hear you.
No, we need you to on the microphone because we're live streaming. So, is it working now? No.
It's number 1.
You've broken it, Sam. Another one is. Oh yeah, that sounded. No. New battery, perhaps. Yeah. Thank you. Yeah, go ahead.
Thank you, Juliet, for talking about social prescribing, which some people feel is soft and fluffy, but is critical for mental health, critical to dealing with the up to 20% of admissions of over 65s to hospital because of drug adverse effects, critical to the opioid epidemic, prescribing the antidepressant prescribing, and is the only challenge in the system, I would dare say, to NICE, which isn't nice as far as I'm concerned. And it's critical to persuading people and communities to invest in their own healthcare and deploying the voluntary sector. That was my statement, but my question is a financial one. When I was leading the vanguards, there were 2 interesting vanguards. One reduced acute admissions to psychiatric hospitals by 1/3 by opening up cafes staffed by health workers over the week, and another run by nurses reducing death in hospital from 47% to 14% with terminal illness. My point is, if you do something in primary care, it's incredibly cheap. I'm incredibly cheap. I'm about 20 quid. But my finance director...
What?
Just think about the phrasing of that.
But when I was CCG chair, I asked my finance director, if I don't solve the problem or I don't have the skills, capacity, whatever it is, what's the cost if I just send that referral to hospital The answer was £628. The minister earlier on talking about her grandmother, well, managing a patient like that in our community with our multidisciplinary team probably costs in the region of a few £100 versus £2,000 a night. So my question to all of the panel is, how much does it cost, or would it cost, if you invest in primary care to keep somebody in hospital versus them being in hospital?
Keep them out of hospital.
To keep them out of hospital.
Yeah, okay. Hang on to that question. It's that's quite hard and quantitative, but we'll ask them, have a go. Bola here in the middle. So just stick your hand up, because I don't think I can see you. Yeah, that's it. Yeah. Good, thank you.
Thank you. Just a question to the panel. When are we going to better articulate the business case for tackling health inequalities? Given that we recognize increasingly that health inequalities actually equal productivity inequalities, and the gap between is multimorbidity, for all the reasons that were alluded to earlier by Juliet, knowing that people in the most deprived communities, they start with long-term conditions earlier, they accumulate them faster, they live with them for longer, they exit the workforce earlier as a result of that. We lose the community capital that they bring, the tax revenue, the higher healthcare expenditure, which I think we've started to unpack a little bit. When do we move the debate out of the moral and ethical imperative into an economic case to tackle health inequalities because of how it translates in across the board?
Thank you. Isn't that your job? Yeah, great question. I'll take one more. I think I've got. Is it Kate? Yeah, it is Kate. Yeah, hi. So, I'm in a slight. Just.
Thanks, Nigel. Kate Arden, Honorary Professor of Public Health at Salford University, and formerly, of course, DPH of Wigan. Hi. My question to the panel is, and I'm very interested, Sarah, that the analysis isn't published analysis. You know, it's not routine intelligence. It should be. I think we would all say that. What does the panel think the cost of living crisis has actually had on the ability to discharge? Because, as you know, I would agree with Sarah that we do actually have enough beds, but they're in people's homes. And Jonathan Brearley, who is the Chief Exec of Ofgem, in a very recent Institute for Government webinar, pointed out he'd been going into acute hospitals and talking to patients who didn't want to go home because they couldn't afford to heat and eat. Now, that's a particular issue for people with chronic respiratory disease, and certainly the work we did in Wigan on fuel poverty, which was commended by the NEA, which was about actually sorting out, not patching them up and sending them back to a cold, damp, mouldy home, but tackling the need to get an energy-efficient boiler in, tackling their fuel poverty, and making sure they can actually eat, afford to eat, is going to be a major issue. It's probably not quite hitting the stats yet, but it needs to be reflected, I think, in the intelligence. We need to understand the impact of cost of living. Thank you.
Very interesting. I remember finding an entire ward of old ladies in a town in Moldova who were there for precisely that reason. It was -10 and it was very nice and warm and they were having a lovely time. There was not much medical treatment in evidence, I have to say, but it was definitely providing a service. Who would like to take some of those on? Nick's historical analogy, I'm not sure, this convalescence, might want to broaden that into other types of institutional types of care that we might be missing. It's very notable when we look internationally that we're a bit short on some of these step down and intermediate care. I think David Oliver has a story in BMJ which reminded me of the intermediate care audits that used to be done that always found that. So who'd like to take that on? Sarah, and then I'll come down the line. Yeah.
Well, I'll just quickly say I think that increased capacity for that step down would definitely be welcome and is needed, but it would need to come with with care, with rehabilitation, with physiotherapy, etc., because the risk is that you might ease part of the hospital bottleneck, but without then the ability for people to go home, for people to be well enough to go home, then you're just shifting the problem a little way down the line.
Yeah, the classic theory of constraints thing, which you just move the bottleneck, turn to the next one. So, so rehab input.
I mean, I think it's a good point. I think when the people that you're talking about that are staying more than 3 weeks, got very complex needs, a whole range of different needs, and that intermediate care and step-down capacity. And again, we use these terms quite loosely and interchangeably. Virtual wards, isn't that part of that kind of intermediate care kind of spectrum? I think what we've seen with the reduction in intermediate care services, I'm using the term now, is actually a shift from NHS care into social care. And I think what we need is a range of options that actually support people in the way that they need to be supported at that point in their journey, if you like, and that can very well be in their own home. But it means that those services have to be much more joined up. A lot of my experience of intermediate care services is that people didn't quite fit the criteria, so they weren't actually responding to the needs that people had. And I think we're only going to be able to respond to people's needs in a personalised way if they're much more joined up services that are much more personalised and tailored to that individual needs. And I'm going to link it to Sam's point actually, because primary care is cheap, social care is even cheaper. But it's not value unless you've got the right skills and services to support and that are kind of wrap around it in order to meet people's needs in the right way.
I'm guessing from both those contributions that you don't envisage Margate suddenly having an uptick, or Hastings, or those other places that they used to be. But of course, Germany still, until very recently, operated a lot of that capacity, and it's still there's still a large amount of it. It is one of the reasons, again, Netherlands has very large amounts of this intermediate step-down care, but they do spend probably an extra percentage of GDP on home care and step-down type care. I'm going to come to Juliet and then back to Tara. Also, Tara, if you will pick up some of the prevention point, and then I'm going to come on to the inequalities question.
Okay.
Yeah, so I agree with everything that's been said. Step-down and intermediate care, absolutely. There are also other really well evidenced proven interventions, like in stroke we've had early supported discharge services for stroke survivors, average length of stay kind of 15-16 days, and then people are receiving the equivalent inpatient rehab every single day for up to 6 weeks in their own homes. It works, and guess what, the economic evaluation of those kind of services is unbelievably compelling, so much more cost effective than delivering it in hospital. I'd also say that where you have a culture of real partnership working, where you've got the hospital, the community, the GPs, the community rehabilitation teams, the social prescribers, the voluntary sector, working in harmony, led by somebody who really forces everybody to work as one team, it's extraordinary the kind of results that you can get in terms of recovery and rehab.
And I would massively agree about the point about not having enough capacity. Whether Margate is the answer, I'm not completely sure. But we've talked about the lack of redundancy in the system, and it came up in our lunchtime session as well that Richard Lewis pointed out. You wouldn't expect any other mission critical service like electricity or water supply to not build in enough redundancy that you could turn a tap on and have water. Why have we run the NHS quite so hot? So extra capacity elsewhere is really important. Virtual wards has come up a number of times. Half of all virtual wards are run by community trusts, the other half by acute, so it's very much a mixture. Just hit the 100,000th patient cared for in the last year. About 4,000 people will have spent last night in a virtual ward. This is quite staggering, given 4 years ago we had almost no examples of digital home care anywhere. We've now got it in every single ICS in the country for 2 conditions at least, and I think the potential for that to expand would be enormous. So I wouldn't go to Margate apart from a nice day out. I would like to be under my own duvet, please, in a virtual ward.
Should we pick up the inequalities question, which I think is there's 2 quite difficult, almost quantitative questions to pick up. Where do you want to, what's your thoughts on inequalities?
So, Beulah, we've talked about this before, haven't we? I mean, I think you're absolutely right about the inextricable link between multiple long-term conditions or multi-morbidity and health inequalities. And I do think we need to strengthen that economic case for investment. I think we've got some data. I'm not sure that we've pulled it together in one place to tell a compelling enough narrative. In terms of solutions, I mean, I am a big fan of the Core 20+5 initiative, and I'm not just saying it because you're here, but it's really data-driven. And I think we all need to get behind that. Let's not invent new solutions. Let's go with what the data and evidence is telling us is going to work and stick with it. Let's not go changing our focus until we've got some demonstrable, sustainable progress and impact.
I might put this question a bit back to Beulah, but you might have a view on this. Where are the gaps, do you think, in the economic case? Should we get the mic? Do you mind me bouncing the question back to you a bit? Because I think it's a really, you raise a very interesting question. But as I was listening to you, I'm thinking, well, I don't know if I actually understand where we're missing the bits of evidence, and what's your intuition on what we will find when we go looking?
Actually, I think Juliet has answered the question to a significant extent. It's to assemble the data in a way that tells a coherent story. So we know the data, as was shown earlier, around healthcare utilization costs. We haven't fully articulated the economic element of it in terms of workforce losses, as I talked about before, the tax revenue loss and so on. I don't think there is an organized body of work yet that brings all of that together, translates it into the overall productivity loss, and therefore the case for investment in tackling health inequalities, either through things like, as you were saying, Core 20+5, which I recognize as a clinical model, but actually in terms of other social determinants. We've talked about cold homes. How many times does somebody need to go into A&E with an acute exacerbation of their COPD before we recognize it's because their house is cold? And rather than thinking about it as a moral gesture from the system to the individual, but actually an investment from the system in increasing and boosting its own productivity. Yeah. I think it's that triangulation of the data and the translation in a more organized way is what we're missing at the moment.
So I'm going to, that's great, thank you. I mean, but your point though, I think raises an interesting question, which is, I suspect, and Sarah, you'll tell me if I'm wrong, but a lot of the people in that particular 14 to 21 group are not working age adults. So there's probably a whole bunch of other people not getting access to rehabilitation and help who don't appear because they're not in hospital, they're at home sick and not at work. And they're not in the data at all, probably, but I may be wrong about that. Is that...
Well, no, I think that, the data that we have isn't broken down by demographics, but I think we can safely work on the basis that a lot of those people would be older. But I think the other economic aspect as well might be the impact on carers, and so people absolutely. Not able to work because they are caring for others. I think the other aspect, perhaps, for this is thinking about the end-of-life care inequalities that we know exist in terms of where people die based on their, on deprivation and ethnicity, and some of those inequalities, again, and some of the assumptions about what services might you need to be able to die well at home. I think there's a lot of potential issues that could be explored around that.
Thank you. Sarah, did you want to come in?
Yeah, I think they are predominantly older people, but not entirely, and I think that there's huge variation, and those inequalities obviously feed into people having different needs and use of healthcare earlier ages, given those health profiles. But it seems to me that bit about unpaid carers is really critical, and it reminded me of a previous life making the case to Treasury for the investment in mental health on the basis of that kind of economic case. So I think there's lots of data there, but it's how do you pull it together. And for me, it is about the social determinants and prevention and all of the things that we were talking about earlier, where you've got a system that's completely focused on acutes often. And I think that health inequalities and prevention are inextricably linked up. So you have to think about it in that context as well.
I'm wondering if we've got Charlotte in the room, Charlotte Patterson, who might have something to say about unpaid carers. Someone's waving at me there. So let's take a few more comments. Thanks. We haven't quite answered Sam's question, but it was very hard. So we'll continue to think about it. I can't see who's there, but hi.
Hi, Edward Kudonga.
Ed, hi, good to see you.
Population Health Management at North East and North Cumbria ICB. Mine is more of a comment, and I guess just to support Bola's comment, which is we need to advance the discussion that health is not just an outcome that we should aspire to. It is actually a very important input for economic development. And so the minimum investment in social care, the whole challenge around the NHS, means that we are not really gearing the population to maximize on the economic regeneration that the country desperately needs. So how do we move that agenda so that it's not seen as, oh, health is an outcome? Actually, a healthy population, you need that in order to drive the economy.
I seem to remember, keep the microphone for a bit, I seem to remember you've done quite a lot of interesting work sort of linking that to the population health agenda. Am I remembering that? Am I remembering correctly? Could you say a little bit about that? Would that be okay?
Yeah, so we are trying to work with combined authorities. So with the Tees Valley Combined Authority, we've done a small piece of work just to look at the economic impact of obesity. So we just chose obesity as a proxy in terms of something that people might think, oh, it's a public health problem over there. But actually, when you start to model the number of people who are economically inactive as a result of obesity-related health conditions, it then got our combined authority interested in perhaps starting those discussions around how do we start to use some of that investment to create a healthy population, because you will need those people to drive those economic regeneration ambitions.
How easy was it to get the evidence that Bola's sort of looking for in terms of the economic? Because I think it sounded, Bola, like you're identifying a bit of a gap in the sort of analysis and research literature here about filling that gap. Was that easy to get, or did you have to do your own modelling for that?
So we have been using the advancements in kind of your data linkages and trying to link the data, certainly from primary care, of the individuals who have got underlying long-term conditions, link that with data that local authorities have. We ran into a bit of IG issues trying to get the DWP data.
Oh, yeah.
But if you can get that, and if you can link that data, it begins to tell you a completely different story, that health and the economy are two sides of the same coin. Yeah.
Fascinating. Interesting. Thanks for that. I've got Sarah here, and then Charlotte. Is that Charlotte? And then there's Tara. So we'll go Charlotte, Tara, Sarah. Keep the microphone movement to a minimum. Charlotte.
Yeah, thanks so much. So lovely to see you all here. This is my first Nuffield Trust Summit, so I'm delighted to be among you all. Yes, you're right about the unpaid carers issue being a hugely important one in relation to patient discharge. And what happens if we have 85% of people coming home, and that's where we want them to be, but when you come out of hospital, often, frequently, you need a little bit of help. You don't come out as you went in. And so it has a hugely important impact on unpaid carers, and we need to think about the social care workforce as including those 5 million people providing unpaid care. I think my one other quick challenge to the panel in terms of thinking here is that in addition to reablement and rehabilitation, I think perhaps we need to have alongside this a really thoughtful conversation about the business of dying and what it means at the end of life, and whether our end goal here is actually that people are living longer, and is that a good end goal in and of itself? And to think very carefully about Victor Montori's recent publication in The Lancet about talking about the process of dying and what that looks like. And alongside that, perhaps thinking about clinical judgment, about the importance of not treating guidelines as tramlines, so thinking about appetite for risk and risk management. That's a really crucial skill to getting some of these decisions about reablement and rehabilitation alongside what is the business of dying? And what does that look like done well? So I'd like to see that perhaps we have a conversation that runs in parallel along some of those deep issues as well.
Yeah.
Thanks.
Yeah. I mean, it all linked together with just making sure that we're doing the right things designed around what the person using the service actually needs, rather than what... I think Tara was next, and then we'll come to Sarah pick up here.
It's Thea. It's Thea.
Oh, it's Thea,
Tara's
sorry.
on stage with you.
Sorry. Oh, God.
Okay, it's fine. It's fine.
Sorry,
we're very
I've got completely
interchangeable. It's fine.
I'm surrounded by trustees. Sorry, Thea, of course. Of course it
so
is.
I'm a trustee of Nuffield Trust.
Yes.
I'm also Chief Executive of Leeds Community Healthcare Trust. And there were just a few points. I appreciate we're coming towards the end. A point I wanted to make to the Minister, which I have made to the Minister before, is that it would be really great if you set up a National Task Force of Admissions Avoidance rather than National Task Force of Discharge. That way you will start to change a conversation. We've talked about admissions discharge, we talked about admissions avoidance a bit, but we continue to have a conversation, even the data we put up, which was about discharge from hospital. If you do an audit, and I tell you could do it in any acute hospital in the country, of 100 people who have been admitted to hospital over that week, in my hospital, which is Leeds Teaching Hospitals Trust, in my system, over 50% of them didn't need to be admitted at all. You have to put your energy into admission avoidance, even if you do it in that proximal place, which is just before the front door, which is what that audit does. God forbid go even further, of course, which is what we all want to do, which is around prevention. I would also say, if you look at the stats that Sarah put up, you have that other box, which was 16%. That other box is fascinating. That other box includes cost of living. It includes certainly the obsession, I will talk only about my own system, of the hospitals in my system who want to deep clean people's houses before they send them home. Yeah. Now, as somebody who runs a community trust, I would find that people have been living in all sorts of conditions for very long periods of time. I'm not saying they're right, but they have the capacity to make decisions. I could go on, but that box, that 16% box, is absolutely fascinating and something that you really need to look into. I could go on, but I'm going to stop at this point.
Thank you, there. Is that part of the general philosophy of trying to get people better than they were when they came in, even without necessarily knowing the baseline? Yeah, great, thank you. Sarah.
Sarah Pickup, Local Government Association and Nuffield Trustee. So I think we're all talking about how do we use the gridlock. We need more step up and we need more step down, and it has to have what is called in the urgent and emergency care plan wraparound support. So that could be primary care, it could be social care, but actually, where do we get the therapists from? So we need more capacity, as the Minister said, but we need different capacity. We need more therapists, and we need support workers. Like domiciliary care workforce is there, but we do need more of the same, but we also need more of the more highly skilled people to help with the recovery, backed by an occupational therapist, for example. We can use spare space in care homes, wash my mouth out, but if we turn it into a space which is about proper intermediate care, with therapeutic input and physical capacity that accommodates people, practicing their everyday living skills to go home. So we can use the kind of things we've got and adapt them and change them. What we don't want is more of the same. We want something different. So how do we get it? The workforce plan has to train it. And Nigel, your incremental support bit in your big picture, the NHS gets real terms growth. Social care doesn't get much real terms growth. But when you've got real terms growth, you have a window of opportunity to
do
change.
Something. Yeah.
You don't have to spend your growth on the same thing you spent your old money on. You can invest it in therapists and community support and more skilled support workers. And linking those things together, that's what we need to do, because we know what we need to do. How do we do it? Incremental change.
Thank you. Just pass the microphone to John next to you, and then there's a hand. I can't see who it is. There's a hand up. Yes, we'll go to you next. Thank you. I just can't see who it is. John.
Thank you. Yes, I'm John Glasby from the University of Birmingham and from Impact, the UK Centre for Implementing Evidence in Adult Social Care.
Well, that's never going to take on, is it?
And one of the few people not to be a Nuffield trustee, actually, I feel. So just a couple of contextual observations, if that's okay. For me, some of this is hardwired into the design of our systems. So when we were researching this, the earliest reference we found was during the Second World War, when before the origins of the NHS, when we were establishing emergency rest centres for people who'd been made homeless in the air raids. And there was concern that those would become blocked by frail older people who were admitted because of an accommodation need, but then would become stuck and couldn't leave because of ongoing frailty. They were called the unbilletables. And actually the language has changed, but that feels exactly the same issue that we're talking about in the here and now. And over time, our reading of the evidence suggests 2 or 3 things. First of all, there's something about really understanding the problem. And sometimes premature discharge or poorly coordinated discharge is just as problematic as delayed transfers of care. Secondly, there's been competing notions of good practice. So sometimes you find an acute model that's based on efficiency and throughput and getting people in, treating them and getting them out again, that butts up against a kind of social care notion of good practice, which is often about empowerment, about helping people going through really difficult periods in their lives make really long-term decisions about what happens next and how they live the remainder of their lives. And it's not that one of those models of good practice is right or wrong, it's just that they're different, and at the point of discharge they come into tension with each other, and we've never found a way of resolving that. And then thirdly, you get competing priorities as well. So when I trained as a social worker, I knew that hospital wasn't the right place for some of the people on my caseload who could come out. Deep down, the people I was really worried about were the 15 or 20 people on my caseload who lived alone with dementia, who might die at home alone, and I'd be the person to find them when I came in as the social worker. I was more worried about them than I was the person who I knew was delayed in hospital. Even though I knew it was a poor use of resources, I knew the hospital wasn't a good place for the person, but actually there were other folk that I was more worried about in terms of just kind of human nature. And then finally, I think there's just something about trying to deliver the right care in the right place at the right time. And I'm conscious that we're talking here about older people and general hospitals, but we've been doing quite a lot of work around people with learning disabilities and autistic people trapped in long-stay hospitals. There's about 2,000 of them. The average length of stay is 5.5 years. 350 people have been in hospital for more than 10 years. And we've got exactly the same problems where all the resources are tied in a really expensive buildings-based service, which makes it even harder to invest in the prevention and the rehabilitation. So moving forwards, I just wonder with your presentation, Nigel, about sort of focusing on the things that we can focus on, whether it's just about trying to focus on what's best for the person and the family, about workers kind of knowing each other well and understanding each other's pressures and constraints, and about trying to kind of do all we can to invest in prevention and in rehabilitation, trying to do it for the long term so that we gradually rebalance the system. But I'm not sure there are any quick fixes or magic answers.
Thanks. A fantastic encapsulation of the problem and some solutions as well, all in one, all tied up. Brilliant. Thank you. Lady there. Yeah.
Hi, I'm Anna from Social Care Future. But I wear quite a few hats, and I think I've got 2 quick points. One is that there's a group of people that I really worry about who go into hospital and they don't have maybe family or somebody to advocate for them. And I feel like I'd love to see some data around that and where they end up, because I fear they are more likely to end up in a care home or something like that than actually that they might not need if they had some more support. But actually, that system is so difficult to navigate that often it does need somebody else on your behalf helping to do that. And I think I worry about people that don't have somebody doing that. My other point is, I think, like, especially around multimorbidity, sometimes we just overcomplicate it a bit. And like I would be one of those people, loads of different long-term conditions. And about 3 years ago, I called an MDT of my life, and I just invited like 15 of the professionals that are involved in my care to an online session. They all came, and none of them had ever spoken to each other before. And what was really interesting was that nothing changed in the sense of like the care I receive in one way, but now when I talk to one of them about something else, that there's an issue or what, they're aware now of what the others, that they are part of a bigger network, and they are also more prepared to do things that are maybe not quite in their normal job role, but they see themselves as part of that overall thing, aiming towards what I wanted from my life, because that's what I called this. Now, most people do not have frankly, the audacity to do that. But I just think, actually, how can we how can we listen to what people want out of their lives, but also how can we just do simple things like pick up the phone and actually like ring the physio or the GP or whoever it is. And I think sometimes we miss the simpler solutions, just like picking up a phone and talking to someone rather than,
Thank you, brilliant, excellent, brilliant points there. Thank you, really interesting. Thank you,
Rebecca Myers, trustee of the QNI, but also a community nurse, and have sat as a carer of somebody developing young onset dementia, so have used the services in different ways. I suppose what I was struck by as we were talking was that some of the things about what enables us to support people is access to expertise, access to reassurance and support, and access at times to continuity, which speaks to some of what was being said over there about the relationships. And when we think about demand and capacity in the health service, we often think about that in terms of what people need doing to them, and then what the capacity is to do those things to them. So I wonder if we can start to think differently about the definition of demand and capacity, and include capacity to think about how do we create space for relationships to be built so that people can have their care supported and access to the different levels of expertise that can support them.
Thank you. Very nicely echoing the last point that was made. I think we'll take one. I'm going to take. Let me see. One. I think I can take one more, and then I'll ask the panel to just reflect. Don't have to pick up every point you've heard, but just sort of pull out for you which were the things. Perhaps we'll take two if you can be very quick. That would be. I can.
Hi, Dilip Paliraj. I'm the chief executive of the Richmond Group. I just want to kind of go back to the Sam Everington made, which is about, we've got models of care that work, right? So I think the discussion needs to be, I love the idea of an avoidable admissions task force. I think we need to have that conversation with government because they've recognised that discharge needs to be fixed, and that's a lot to do with social care and intermediate care. But no one's looking at the front door. So I think we need to address the front door. But I think the question we need to ask is, we don't need to reinvent the wheel. There are a lot of models out there that do work, but they don't exist everywhere. So neighbourhood teams give us an opportunity to design into ICSs multidisciplinary, proactive models of care. So the questions we need to ask are, what works? Why does it work? How do we scale it up? How do we spread it? And what does government need to do to facilitate that and accelerate it?
Just slightly careful what you wish for there, I suspect. I think time-wise, I'm going to come back to the panel because I think we have to finish at 1:45, not least because one of our panellists has to go off and chair our meeting. So, beg your pardon. I know a number of people still want to come in. Let me come down the line. I'll start with Juliet and come.
Great, thanks, Nigel. Fantastic discussion, so much expertise in the room. So, three reflections. One is I think we need to value more than we do today non-clinical solutions. Because I think we tend to look at the challenge through a biomedical lens, a biomedical model, and so much of what people need and want when they're back at home is actually more social solutions. It's things like the opportunity to connect and get peer support from people going through the same condition as you. It's the importance of people like social prescribers who make a massive difference in connecting people to available community support services. Let's value non-clinical solutions and let's evidence their value more effectively. The second is around the capacity challenge of thinking about capacity differently. I think the reality is we're never going to have enough specialists in the community, but I think we can augment and better meet needs through use of appropriately skilled and trained volunteers, for example, through support workers, key workers, case managers. There's loads of evidence that they help people to stay well at home and not be ill in hospital. So I think we need to challenge ourselves to be a bit more creative around the workforce challenge. And then the third thing is the simple solutions. Yep.
Simple
Keep it simple.
solutions. Very good. Tara?
Thank you. And one of the things that's been so interesting working in digital home care is the amazing feedback from patients. And as Rebecca was outlining those important things, that's what people talk about. They talk about the tech is the least interesting bit of it, right? They talk about excellent nursing care. That's what it looks like. And the technology is an enabler for that. So, and just, we haven't mentioned that patients love it, and it feels like that's a bit of an omission. So I just want to state that one. Admission avoidance was exactly what I was talking about. So virtual wards, there are virtual wards that avoid admission as well as do early discharge. And then the final bit is that holy grail about capacity and getting occupancy down, because what that means is an elective program that can happen every month of the year predictably. That means cancer operations happening. It means waiting times down. It means less clinician burnout and people actually being able to have a tiny break and a cup of tea and keeping our workforce with us. So I just think it's difficult, but we should keep our eye on that prize and think of other ways that we can make our hospitals less hot.
Excellent.
So absolutely agree. I think we need to have that focus on how we support people to live well at home and stop people going in to hospitals. I think if we're honest, people's experience, particularly older people of multiple hospital admissions, it's not a good experience for them. And it's your point about how I think it talks also to the point about how we think about dying and how and where people might want to die and how people can be supported by the system in their own homes. I think that workforce point is really critical. We sort of touched on that. Sarah talked about that we need more therapists, etc., if we're going to have these sort of recovery services. But actually, we probably need to look at a whole range of roles and what we really need. We've got a workforce plan for the NHS we've not seen yet, but we've got no thinking going on about a workforce plan for social care and how those two things might connect. But then I think also those points about giving people time, really, in a system which is running very hot, it's hard, but people time to build those relationships and networks and think about how services work together around the person.
And just finally, more data and evidence and leveraging this to better understand what's going on, which will help us get the focus away from hospitals and into what's going on in community services and social care. So there's a lot of development going on in this area, but we need more of it, and also to think about how we draw on feedback from patients and voices from patients and families to really understand what's happening.
Thank you. That's all been excellent. I'm actually left with some questions, which we may need to consider out. So Bola's intervention made me think that we are missing some evidence and some ideas about, and we're particularly missing probably what's happening to the working age adults and what the opportunities are there, because they're not appearing in the hospital data and they're probably not appearing in the community data as much as we might. That seemed one thing. Second challenge, I think, I'm all for preventing admission. How do you prevent that bed being filled by somebody else? So there's something about how we need some complementary changes in the admission processes in hospitals as well that would go with that. There's a little bit of a division about, well, we know what to do, we just need a bit more of it. But Sarah and others have sort of said, well, actually, that's not quite right. There are some different models and some different ways, and I'm left thinking that perhaps a little bit more thinking to be. I think probably we do know a lot about the basics, but I think it sounds like there's some other things we need to think about making sure this really delivers. I'm very struck by having to convene your own case conference. And then people using the term navigator. If you need a navigator, could it be that your system is too complex? Yeah, I mean, it may well be we do need navigators, but we could get a bit of a head start if we at least had a map. And maybe if that map was a little simpler. And I think this idea that then the professionals know how their bit fits into other people's and then how to make accommodation and work in a more collective way. And then I thought John's contribution there was just sort of a really elegant example of how to tackle a problem and give an answer. And I will go back and listen to that on the... you can go back and listen to that as well. So there's lots of interesting bits of further work to do, I think. We know quite a lot. We haven't implemented quite a lot of what we know. Quite a lot of what we've got is quite complicated, and we haven't quite got the data that we need. And we need a bit of a workforce plan. And end of life needs more attention. That's my summary. It's tea time. Thank you very much. Thanks very much to the panel, and thank you to you all.